I once again welcome you all. We now begin with the next session of the day. We'll have a scientific talk by Dr. Asima Pradhan, and I would like Ms. Shannon to come on the stage to introduce her.
Good morning to everyone present here. It is my great pleasure to introduce our next speaker. Dr. Asima Pradhan is a professor, Department of Physics for IIT Kanpur. Completed her PhD Physics from City University of New York. Her specializations lie in the field of biophotonics, laser spectroscopy, optics, biomedical imaging, and spectroscopy. She has over 1,800 citations to her name, with her major research interest being in the area of biophotonics, attempting to understand tissue fluorescence and light scattering in human tissue environment, and to evaluate its use for diagnosis of disease. In 2015, a student from MAM's team had won the Gandhian Young Technology Innovation Award for the development of a device to aid in cancer detection. Future interests are to explore ways to improve such diagnostic capabilities in order to take it towards the desired goal of non-invasive and early detection of disease, specifically cancer. Today, she will be speaking on the various dimensions of fluorescence-based diagnostics of cancer. Without any more delay, I give the dais to Dr. Asima Pradhan.
I'll hold it. Thank you. I'd first like to thank Dr. Mahato and the organizing team for inviting me here. It's a pleasure coming here. This is the third time I'm here. And I see a big difference. I see more enthusiasm. I see more students involved in this. And it's a good thing that the Optical Society has brought in this student chapter, which is really nice because students get to organize and to hear good talks. We've seen this in IIT Kanpur too. And so I'm happy that I'm here. Today I will talk to you essentially trying to get to the students to get motivated to this area. I have worked on, sorry. I don't know why this is. I think. Is that okay? Can you hear me? Yeah, this may fall. Okay, so what I'll do is I'll talk to you about the work that I'm doing with giving you some basics initially. So we talk about the various dimensions of fluorescence-based diagnosis for D cancer. And somebody please tell me when I have 5 minutes left. So I'll start with telling you how tissue optics developed. That's the area that it's gone to. It's called tissue optics. And I have a slide here which I like to show. This is where you have I have in my lab, put a tissue, put a fiber, put light on it. So there's blue light. And what you see is light which is scattered, and you have this diffuse light here. This is what you see. If actually you can't see this too well, but if you look at this, I have a cuvette and I have water and some scatterers, some microspheres here, very dilute. So if you see when they are dilute, you see the spread of the light is not much. Make it more concentrated. This cuvette is like this. Make it more concentrated. You see the light getting more scattered. There's more diffuse light. And if I have higher scattering, then I see light to be more diffuse. And that's exactly what happens in the tissue. So this is what you get. One of my slides which I like, so I'd like to show that. So in a tissue, you have, when light is incident on the tissue, laser or even a lamp light, what you see is, you'll see the light that's reflected. You see, you can detect Raman scattering from there, fluorescence from there. You can, the light gets absorbed, sorry. Light gets absorbed there and transmitted if the thickness of the tissue sample is small. Okay, you have microns, you have about less than a millimeter, you will see the light that's transmitted through it. I'll come to these two later. So what I have over here is my hand. I put a torchlight here, and most of you have done this when you were kids, I'm sure, that you have red light, which is which you can see, you can scare people through it, right? That's what you've done maybe. I think the students can appreciate this. Yeah. So this is a torchlight and you get red light out of it. Many years ago, I had a relative of mine who asked me, what is this? Tell me why this happens. And it was almost like a challenge to me because I was doing my PhD at that time. I wasn't thinking about this. And I said, oh God, I mean, I should know. And I was traveling somewhere. On the way, I tried to figure out. And so I figured out, of course, that what happens over here is because if you ask anybody, they'll say blood. Okay, right? So that's what happens. It's true. You have the light, the visible light, the blue light is the one which gets absorbed more. Okay, and what you have is more retention of the higher wavelengths. So you see more of the red light, and the red light is also scattered more. So you have absorption and scattering both playing a role, and you see this red light over there. Okay? So this is interesting. I find that very interesting, essentially because my relative was a doctor. He asked me this, and so you can see that we should know what it comes from. So the wavelength of light is important. The penetration depth of different wavelengths of light play a role in what part of the tissue you are looking at and what you would like to detect. So basic aim over here, in my case, is to detect early stages of disease, in particular cancers. So what are the changes that you see? Increase in the size of the nucleus, cells are packed. This will give changes in the elastic scattering. Increase in metabolic activity, because there are tissues, there are cells which are growing fast. So there's metabolic activity and you have biochemical changes that occur. The fluorescence yields changes. Then bonds can change. That might give rise to some changes in the Raman scattering. Blood concentration, early growth, early changes in the tumors, you will have blood flowing into that region, essentially because it needs nutrition. Okay? It's going to grow. There are more cells growing there. So you will see absorption changes. So what I have here is, you can see over here, again, I did this in my lab. I like to do these. I haven't done it in a while, but I used to do this earlier. Put a chunk of tissue and put a fiber. So I have a fiber here which is not in the area which is which has blood, and this I moved that fiber or move the tissue to the area where there is blood, and you can see that here I did this in the light and I had to put it in dark so that you are able to appreciate what happens to the spot size. Okay, the spot, as you can see over here, is larger, and here it's smaller, essentially because quite a bit of the light has been absorbed. Okay. So scattering in tissue occurs, these are caused essentially by random spatial variations in the density and in the refractive index, okay, of the cellular components, subcellular components, and it's all mostly described by the Mee theory. You will also have Rayleigh scattering, Mee scattering, Rayleigh scattering. You have a hierarchy of the ultrastructure. This is a typical figure that is used by many of us. Okay, so telling us what are the sizes of these cellular structures and where Mee scattering and where Rayleigh scattering plays a role. So this gives you essentially the morphological information. Again, here you can see I have the tissue, the same one that I had in the beginning, and you can see the blue light that's put in there shows up as the elastic scattering here. Go to the next slide. It's of course telling you about the absorption. I put that figure here again, but not necessary. So what you have is the absorption of skin, aorta, and blood absorption all given over here. So that's also absorption is strongly wavelength dependent. Typical values are given, and there is a therapeutic window that many people use where they don't want to use absorption as a parameter. So you want to go deep, you use the near infrared region, 700 to 1000 nanometers. The biochemical aspects are probed through fluorescence, and there are people have talked about many of these probes that are used. You use nanoparticles, you use maybe other fluorescent probes, okay, which is very good, which is actually what we need. But there is also the fact that there is fluorescence, there is native fluorescence from the tissue itself, which one can probe. So where does that come from? From the coenzymes, the structural proteins, okay, they all fluoresce. And one would think that, they fluoresce. So where do we see it? I mean, the strength of that fluorescence is weak, of course, but we can measure it. So I always mention this also, that if we are placed in the dark and placed in the right environment, we'd all be glowing. Okay, so that's essentially what is happening. There's light which comes out naturally from these fluorophores, and that depends on the wavelength of light that you are using, which gets absorbed by the fluorophores. Okay? And here I have the blue light put in here, but instead of that blue that you saw, you see a green now. Okay? Can you tell me why I see a green? Of course, I haven't told you how I made it green. So this is the fluorescence. What I did was I used a filter and I took a photograph. Okay? So I removed the incident light, the scattered light, and what I saw was the fluorescent light only. Okay? But the fluorescent light generally would be somewhere in the yellow, dominated by the fluorescence from flavins that generally show up in tissue fluorescence. I used to wonder sometimes, why did I get green? But I think the reason is that you have a filter. The filter does leak out some of the scattered light, the elastically scattered light. So you have a blue, which is leaking in. You have the yellow, and blue and yellow are giving me the green. Okay? So if anybody else has any other idea about that, you can go ahead and tell me, but I keep saying that is what the reason is. Okay, so you have many of these fluorophores, and you can see the fluorescence spectra of endogenous tissue fluorophores, huge number of fluorophores that you have, and the excitation spectrum. So you have an absorption on one side, you have the emission on the other side, which shows up, and they cover up from, say, around 300 nanometers to 700 nanometers, all through the visible region and also in the UV region. This is one of the spectra, the fluorescence spectrum that I like, because one has actually fitted it with either a Lorentzian or Gaussian. I actually got it from somewhere, but we also do this. We use a Gaussian and sometimes a Lorentzian or a Voigt function, which is a combination of the Gaussian and the Lorentzian. So as to see whether we can, which is actually maybe most probabilistic, you see all the fluorophores. Oh, sorry. You see all the fluorophores that play a role in the tissue fluorescence. So it's a broad fluorescence profile. Okay? What are we targeting? How do I know what I am targeting? That sometimes becomes a problem when you do tissue fluorescence. So I have already mentioned all this to you. So when did it start? Okay. 80s, early 80s. 84 was the first paper on rat tissue fluorescence. Okay. And the Alfano from City University, who's my supervisor, Michael Feld from MIT, were the ones who started this work. And I'm lucky enough to say that I'm happy to say that I'm lucky enough to have been there And I was one of Alfano's first students to work in this area. He was actually more interested in this as a hobby, and I just happened to be there wanting to do biophysics. So we got into this area. So first generation task was only in vitro experiments, keep getting tissue, keep doing all these experiments. Then not only with fluorescence, but with many of these: elastic scattering, Raman spectroscopy, absorption, optical coherence tomography, which you may be familiar with already. OCT is something that many of you now, if you go to the, I don't know if your medical, if you have an eye hospital here, OCT is so commonly used now. Okay. In fact, I got a shock once when I saw OCT over there, and I was wondering what it is. Could it really be this? Because in my lab, my student says, I want to do OCT, maybe we can develop a tool and do this, but it's already there in the market. My mother had a eye problem, and she had an OCT image right there. So this is all Michelson's interferometry. Right? So very nice. Then second generation bring technology to clinics. From 2000 onwards, it's been going on. How many things have come to the clinic? It's difficult, but it's there. There are actually devices which have come up, commercially available, and still people are trying to use novel approaches. Okay? And the current issues, you keep on improving the diagnostic capabilities, use different algorithms, okay? Image processing. So there are many open areas, okay, that are used. So this becomes really a multidisciplinary research. Okay? So this is one of the first fluorescence spectra of human breast tissue. I worked on this. So I'm just showing you, not because it's one of the first ones, but because you can see that this is noisy. Let's forget about the noisy. That's only because the signal was weak. But you can see there are a lot of variations here. There are dips, there are bumps, and it kind of, we worked on it, said, yes, this is fine and all that, and we got these statistics, everything was fine, but didn't know exactly what was happening at that point. Okay? You have one band here, another band here. You say, oh, maybe it's two fluorophores playing a role. Okay? But two fluorophores which are distinguishable from each other, we're not very sure. Okay? So we thought it was so, that's it. So then what are the different facets of fluorescence? Spectra, which you just saw, okay? Polarization, which I will use, and lifetime. All these things can be used to strengthen the diagnostic capabilities and to understand a little more about what's happening in the tissue fluorescence. So given their individual strengths and limitations of these techniques, one can talk about a multimodal approach. Multimodal approach was just talked about this morning, and very nicely put about fluorescence and using MRI. And so you can do these things optically also. There are a lot of people doing it now, and not very easy all the time, but it's doable. So when light propagates in the tissue, what do you have? You have scatterers, that the cell membranes, they will give you a refractive index mismatch, and you'll see scattering. Okay, so let's first, just looking at the scattered light, you will see that the light, if there's hardly any scattering around, hardly any cells, it's dilute, you will have what is known as the ballistic photon. So the light just travels through straight, and you have the ballistic light. If there are few scattering events, which occurs if there are, if you are not going very deep inside the tissue, then they are known as snake-like tissues. If there is a lot of scattering, then you have diffuse light. So by space gating, you put an aperture, maybe you will get the ballistic. This is very simplistic, doesn't really always happen. You can have time gating, because the ballistic light will come out very fast, femtoseconds. Okay? Snake light takes time because it's getting scattered a little more. Okay? Diffuse light scatters, and so you will see it takes a little more time, slowest transmission. So you can do a time gating, and look at, you can capture whichever one you want for whatever diagnostics or whatever your interests you have. Ballistic is not always easy. I mean, snake-like is what you actually get in tissue. Uh, Polarization gating, because you can see if you allow light of a certain polarization to go in, as it gets scattered, if it's not getting scattered at all, it'll come out as the same polarization. If it doesn't, if it gets scattered, you see that the polarization changes. And if it is highly scattered, it gets totally depolarized. So this is your what is known as the polarization gating. You can put a polarizer and an analyzer and you can look at this. Simplistic view, okay? Now, what I concentrated on was cervical tissue, okay, cervical cancer. Women in India have big problems with this because in rural areas, there's no detection, there's no checking, okay, no screening. So people do have problems. Women in cities also are not always aware of this. Okay. So around 73,000 women die of cervical cancer every year in India, world's top death rate. Okay. So out of total number of women dying of cervical cancer globally, more than 1/4 is from India. So regular screening is important. So, is this not going? You have different techniques that are used, pap smear, colposcopy, and all have a certain specificity and sensitivity, but which are not 100% either way, right? So, and what you really need to do finally is have a biopsy, pull out a tissue, do a histopathology, which takes time. And let me also warn you that whatever I'm talking about is not something that's going to change the scenario completely. You have to have a biopsy and a histopathology at this particular time. Sometime later, I hope we will get rid of everything and have only the optical screening. Okay? So that's so far I think I would say half a dream maybe. It's halfway through maybe, and so this obviously is not good enough, and people are working on different optical techniques. Human papilloma virus tests are being done, but that also has to be done, and then a pap smear has to be continued after that. Okay. So, like I said, optical techniques, fluorescence, spectroscopy, imaging have the potential to diagnose. I go through all this, went through all this. When what I will go through now is telling you that if you have polarized light, I've already told you this, if you have polarized light falling on the tissue, then because of scattering, you will see changes in the polarization. Okay? So if it hasn't gone through too much of scattering, then you will see the co-polarized light, the light which you had, the polarization you had in the incident light is still available. Okay? Majorly available as compared to the cross-polarized. If you go even deeper, then you have equal co and cross-polarized light. So that is where the light has become diffuse. Okay? So if I now am able to remove one of them, that is the co-polarized light, then by doing a subtraction of the two, the co and the cross polarization, then I will be able to look at the information that lies in the superficial layer, because that if I do a co minus cross, I'm actually limiting the light which has only gone through very small scattering events, which means that it has only gone through the superficial layer. And that is what I'm interested in. Why am I interested in that? Because in cervical tissue, okay, the problem starts at in the epithelium layer. You have the epithelium layer, you have the stromal layer below that. The epithelium layer is where the cancer, the cells start growing first. Okay? So you have cells growing to the density increases. 1/3 of the epithelium is very dense. So that's the first stage. Then the second stage, when you have 2/3 of the epithelium. Then the third one is when the entire epithelium is thick, very dense. And then the there is the cells are growing downwards, infiltration after that. So this is one of the techniques. This, I said that co minus cross. I wanted to show you this. This is something interesting that other people have done also. We did this. Take a needle inside water. Okay, you can see the needle. Put it in milk, okay, or intralipid, which is a scatterer, and or microspheres there, and you don't see the needle. Okay, do a co-state. You can still see the shadow of the. If I do a transmission, I can still see the shadow of the needle. Cross state, I don't see it because, as I said, the scattered light goes through and it's in front of the needle, so you are not able to see this. Co minus cross gives you a very nice discrimination. You can actually see the shape of that needle. So this is something that we have also used in fluorescence. I'll not get into this. I just said that. Okay. So what is the idea? Remove the scattering effects, because finally what do we want? We want the fluorescent light as it is, without the effects of the scattering and the absorption. So you want to remove the scattering effect, you want to remove the absorption effect. And to do that, the assumption we use here is wavelength dependent scattering and absorption, similar effects that they have on polarized fluorescence and polarized component of elastic scattering. See, because scattering and fluorescence have two different wavelengths that you're looking at. So the scattering coefficient, absorption coefficients are slightly different. But here you assume that they are nearly equal and go ahead with this assumption. If I take a fluorescence of the fluorophore that exists inside the body, okay, then you will see that this is the fluorescence spectrum. Add blood and scatterer in there and you see these dips. You remember the breast tissue spectrum, it had these dips. Okay, that's when we could figure out that that was absorption due to blood. So what we want is the intrinsic fluorescence, and this is what you see. The emission spectrum you have over here is from the measured, this is the measured spectrum from a tissue, from a cervical tissue actually, and you can see that there is a dip over here. Do the intrinsic fluorescence, that means do a subtraction of the two polarized components, co minus cross, and you will see the entire spectrum without the dip. Okay. So this is the algorithm that we used. You actually need not go through the whole thing. This is just that there is a co minus cross fluorescence divided by co minus cross elastic scattering. So what you're essentially doing when you do co minus cross, you're getting rid of the diffuse scattering. And when you divide it by the elastic scattering, since the elastic scattering is also going through similar path, it's also going through similar absorption processes. Okay? So if I normalize with respect to that, I can remove the absorption effects. And that is what we checked. We actually did this work on tissue mimicking phantoms, checked it out, gave us very good results, published in much earlier in Optics Express, and then did it on tissue, okay, in vitro. So this is co and cross polarization, elastic scattering, divide one by the other, and what you can see over here is the intrinsic fluorescence, the green one. Look at this. This was all absorbed and it's come back. Okay? So you're able to get back what you lost. We did a principal component analysis on these data. Okay? You have huge data here because you have 200 wavelength data, and because you're going from say 500 to 700 nanometers and you have so many patients. So take a matrix, form a matrix and do a principal component analysis, and you can do get the map. Okay? If you get the map of this, okay, this turned out to be interesting because you can see over here the co for the normal and the cross for the normal didn't give us such good, well-defined domains. But if you look at the intrinsic fluorescence, it gave us these nice domains over here, which we could correlate with the different fluorophores. Okay. So there are these many fluorophores. If you remember, I showed you a spectrum which were fitted with this Gaussian, and you saw so many of these fluorophores. So you actually pull out those fluorophores through this principal component analysis on the intrinsic fluorescence. It's better with the intrinsic fluorescence because you're able to remove the absorption and scattering effects there. So it's purely the fluorescence. So let me not go into this. This is what we did for the early cancers. Okay? And this is the CIN1, CIN2, and we saw big differences between them. Did a Mahalanobis distance for validation, and the training set after that saw that we could find a good sensitivity and specificity. It actually turns out to be 100% in this case, but it always seems to be 100%, but then when you actually go to reality, go into the patient, things are going to be different. Okay. So take this forward. Okay. So this is something that I wanted to tell you all, that you do this much, leave it, is not really a good idea, because taking it forward is the most difficult task. I can tell you that because we are doing it. It's going to the hospital, trying to work out a collaboration with them, which you always have, but you bring in tissue, do the work and go, it's different. Go to the hospital, work with them. Okay? They have to understand you, you have to understand them. And this is where we said that, okay, since we are getting good results, let's make a tool, a device. So we started in the lab, got a rudimentary portable device, developed, tested it, first on tissue mimicking phantoms, and then on tissue samples. Did a lot of this work. And this is our device, where we had a polarizer, we had an analyzer built in there. And finally, what it looks like. This is what it looked like initially. Okay, so if I show you this, I have a colleague who said, "What are you going to do? Are you want to kill people?" It looks like a weapon. Okay, so but that's what what happens. I mean, initially that's what will happen, and then slowly you refine, you make it better and better. So right now we are trying to make it even better. But this is what we had. We wanted to make it motorized, so we had this huge motor, and things were kind of all right, but still automating is not very easy all the time. We are trying, this didn't work. We actually do it manually now. And the doctor who works with us likes us to use the handheld one manually at the moment. Okay. So this is, so initially we didn't do in vivo, we did in vitro in the hospital. So we took a full uterus sample from a hysterectomy, and you can see this is the uterus. And what the doctors do is go around 12 o'clock, 1 o'clock, 2 o'clock, and they go around this region. This region is the endocervix. Around that is the transformation zone. Okay? That's where things are changing. And then you have the outer zone, which may be normal. In a full-grown cancer, you will see it's all bloody and it's all tumor. Okay? We've seen patients like that. So this was done. And you can see, I don't want to show you too much of all that. So the intrinsic fluorescence had a porphyrin peak, and this played a role in the diagnostics. Though, of course, when we were doing the statistics, we always use the entire spectrum. And did a linear discriminant analysis on it. I will not go into details of it, showed us good results. And the portable device, after it was fabricated, we put it in the hospital. We are now working in vivo on patients, and we have a collaboration with the medical college there. Of course, I have had it for a long time. This is a collaboration also with AIIMS Bhubaneswar, and we have started working with them too. So we have a high specificity sensitivity with this. Oral cancer, since we were doing cervical cancer, we decided oral cancer is something that is also well known in Manipal. People are doing it, in Arakat people are doing it. Everywhere that becomes easier because accessibility is easy. Okay, so people started with in vivo very quickly. I didn't work on in vivo, on oral for quite some time, but then we decided we'll make a probe. People generally use a fiber probe. And fiber probe, one of the advantage, of course, is huge, but the disadvantage is you are actually probing with one fiber, and then the other fibers around it are collecting. Here, if I use a tube like this, I'm irradiating the entire area, and I'm also looking at the entire area, the fluorescence from the entire area. Okay. So we got huge porphyrin bands in this, and using this, the entire spectrum, you could actually take a ratio of the porphyrin band, porphyrin to the FAD. Okay. So you can see that for the buccal mucosa and the lateral border of tongue, dorsal surface of tongue, all three gave us good results, except that the lateral border of tongue gave us a better result. And this, my student used the Mahalanobis distance as the discriminating factor, discriminating algorithm, statistical algorithm actually. So this is what he did a PCA, and I'll not get into all this. But we did get a good sensitivity. He has not put in that, I think. I'm sorry, somewhere there. Now, when I talked about this, I told you how much time do I have? Is anybody checking on the time? Okay, I have about 10 minutes, right? Okay, so then when I talked about this, we said the fluorescence is broad. We have so many absorbers, so many fluorophores there. And it's always nice to be able to look at maybe just one of the fluorophores and then target that one and keep checking on what's happening to that fluorophore. That would be a better diagnostics maybe. So what we did was looked at the synchronous fluorescence spectroscopy. Now, for some time, I quite didn't understand synchronous fluorescence. Okay, truthfully, it took me a little while. It's simple, but it took me time. So what you're doing is you're scanning both excitation and emission simultaneously. So as you scan simultaneously, you'll hit a point where the absorption and the emission for one of the fluorophores is highest. So you will see a sharp peak there. And that is what is good for making fluorescence more specific. We know that fluorescence is more sensitive, Raman is more specific. Of course, Raman is very specific, no doubt, but this can be made specific to a certain extent by using synchronous fluorescence. Okay. So the emission spectrum is there. If I take the spectrum, this is done in my lab, you do a NADH plus FAD. So you take these two coenzymes, you take a mixture of them, and what do I see? I see a broad spectrum here. I don't know where what is. Again, I'll have to do a fitting. But if I do a synchronous fluorescence, then this is what I see. 360 is the excitation. I have a offset. So what I actually do is you are taking scanning the excitation, and you are scanning the emission with an offset. Okay, that offset is actually dependent on how far away the emission peak is from the absorption peak. Let me see if I have a yes. So you can see here, this is the absorption and emission for the different fluorophores. If I look at, say, flavin or NADH maybe, NADH, this is the emission for 60, and its excitation is here, okay, 340, this one. Okay, so this to this is about 100 nanometers. So this is 350, that's about 460, so about 100 nanometers. So if I put an offset of 100 nanometers, I'll be able to get the NADH and not so much of the other ones. Okay, but let me again warn you that this is not true that you don't get the other ones. You will get some of the other ones also. In clear, in tissue, you do get broad spectra, and you see all these fluorophores together. except that the spectrum looks sharper. Okay? So we did this on tissue, and I showed you that spectrum. What we did with tissue is that we did a synchronous fluorescence, but we also did a correction on it. Because when you do this, again, as before, we see these peaks, but you might be missing out on some of them because the absorption eats away some of the fluorescence, as I said about the intrinsic fluorescence. So here also we did the same thing. We actually divided it by the elastic scattering with an offset, and you can see that here, if you have FAD fluorescence, you have the elastic scattering here, and the extracted fluorescence that you see over here matches with the fluorescence FAD, fluorescence of FAD. Similarly, we did it with two fluorophores. Two fluorophores also, the extracted and the FAD plus NADH both match pretty well compared to the measured fluorescence, which is this. It's all eaten away by the absorption. So this was something that we didn't quite continue. We did this on tissue again. Okay. I would have wanted this to go ahead further, but my student graduated. So this is something, that's why I tell you that you graduate, but there should be a continuity and there should be more students doing the same thing so that it can be taken up to a certain point. So this is what we did. Tissue, you can see over here, we did pull out a missing band over here. Okay? And the peaks also got sharper. This is your measured fluorescence, as I can see, yes. And you see sharper peaks. So this was actually quite a good result for us, and we worked on it, did the corrected measurements and did normal and dysplasia. You can see the bound NADH shows up more in the dysplasia as compared to the normal. So again, I will not get into this because lack of time. So we did some work with many samples, but didn't go ahead beyond that, except that I still wanted to see whether we can make a tool out of it. The fluorimeter that I have is huge because, I mean, if I want to do emission and excitation scanning, then whatever it is, it's a big system. It's difficult to take to the lab, to the hospital. So we were trying to do this, want to make it even smaller. It's not worked yet, but we are trying to make it such that it will be useful in the clinics. Other dimension that we talked about is fluorescence lifetime imaging. Okay? So lifetime imaging, what is fluorescence lifetime? You're looking at the time spent by the molecule in the excited state, and it's one of the characteristic properties of the fluorophore. So again, fluorescence, you can see that if your concentration changes, then the fluorescence, the static fluorescence that you see is different at different positions. But the lifetime remains constant. Lifetime is independent of the concentration. So it's another angle to detection, which will give you some extra information. Okay? So factors are environment of the fluorophore. The lifetime is affected by the environment of the fluorophore, and of course, not get into this. So what is the advantage of this? Steady state fluorescence, somebody talked about photobleaching today, right? So you have photobleaching in steady state fluorescence. Lifetime is independent of that. And overlapping spectral data of different fluorophores affect diagnostic capabilities. That's why we said synchronous is something that we can work on. But time resolved fluorescence also helps because we are not dealing with this. Each one of these spectra have different lifetimes. So it can distinguish different fluorophore markers and independent of fluorescence concentration. So you can actually accurately maybe demarcate diseased region from normal region by using fluorescence lifetimes. Here I can show you that the average lifetime decay time for a pixel, you actually, what do? You find out the, you look at, you generate many frames, okay, at different times by giving a delay. Okay? You give a pulse and then look at different delays, you generate the steady state image. And then from those image, pixel wise, you can actually find out the lifetime for every pixel. That is what the lifetime map is about. Okay? So if you look at the lifetime map, then you sometimes miss out on one of the fluorophores because the intensity, if you look at the steady state map, okay, you miss out on this because the intensity of the other one is very high. But in the fluorescence lifetime, the lifetimes are different. There's a lifetime map actually, and you can see both of them, one with a 3.4 nanosecond, the other eosin is 1.4 nanosecond. So this is one of the advantages I just wanted to show you all. And people have worked with film for some time now. Okay, Lacowitz first, Periasamy, then instrumentations have been developed, and now you have systems which are small and can be maybe used in the clinics. This is Paul French has actually worked tremendously on this. Okay? So we have done some work where lifetime imaging has given us good results from cervical tissue, and I will not, using lifetime and then principal component analysis on it has helped in giving us a better resolution on the parts that we could not see by steady state fluorescence. So if you look at this, here is the tissue. Okay, this is the cervix, entire cervix. We took part of it, cropped it, and looked at it. Okay, this is 3 centimeters, it's about 3 centimeter, about 3 centimeters diameter. And then this is the area that I told you that we have the endocervix, and this has high absorption. You can see this. This is the steady state map. This is one of the averaged steady state map that you see. Okay, you can see over here. Now, lifetime does a better job because it has actually shown you which are the the regions which have a problem. Okay? On the lifetime map, we did a principal component analysis. If you look at this, this kind of gives you a better resolution, okay, as compared to this. But if you look at the second PC, okay, that's if you look at the second PC's vector, you will see over here the resolution gets better. Okay. This is the result that we got interested in because again here, because lifetime, I'll show you in the next slide. Over here, we did a phantom study on this, and you have 3 different cuvettes. One, just the fluorophore, one fluorophore plus absorber, one fluorophore plus scatterer. You can see the lifetimes, the scattering shows up, okay, in the steady state, in the lifetime, the lifetime of the fluorophore plus scattering is higher, whereas the lifetime of the fluorophore and fluorophore plus absorber almost have similar lifetimes. Okay. This is the intensity map. You can see that the intensities don't show too much of a difference. Forget about these parts. This is actually because the Gaussian beam that you have, which gives you an intensity variation. Okay? This variation may be misleading, okay, for a fluorescence steady state map. Go to the lifetime map, you don't see that intensity variation. So that's a good part of it. But you can see that the fluorophore and the fluorophore plus absorber don't give you any differences. Scatterer, when you add scatterer to the fluorophore, that gives you a different lifetime. First PC on this doesn't give much difference. Look at the second PC. Fluorophore, fluorophore plus absorber, fluorophore plus scatterer. All 3 give you distinct differences. Okay? So the second PC actually helped in getting the absorber and the scatterer information distinguished. Okay? So we also did a double exponential fitting on this. We were doing all this by doing a single exponential fitting, and double exponential fitting has given us some good results. I'll not get into it due to we don't have enough time for this. So in conclusion, I'll say that intrinsic fluorescence is one of the sensitive tools for early cervical cancer. Portable probe that we have fabricated and validated. We are doing the clinical testing now. Overlapping fluorophore spectra hampers the detection. So one goes into synchronous fluorescence. Okay? And there also we see absorption effects still mask the signatures, do a correction on it, and that shows promise. And lifetime imaging is another dimension where the second PC captures both absorption and scattering effects. And this actually one can maybe do a multimodal detection if it is possible to do so. So I'd like to finally acknowledge all the funding agencies that I got money from, and also my collaborators in the medical college who I've worked with for more than 20 years now, and also my students who have been involved in these three works are from the physics, and I have one student from the Center for Lasers and Photonics, which is a interdisciplinary program. I have one from the Biological Sciences and Bioengineering, who's working on the device fabrications. So thank you for listening, and I hope this gives you some idea about the difficulties that one goes through in actually bringing something up to the clinics. Okay. So thank you.
The session is open for questions.
Thanks, that was very interesting. Can I ask a very naive question?
Yes.
So fundamentally, is the fluorescence emission from a random molecule polarized, or is the polarization coming from the asymmetry of the molecule, structural environment? I mean, the fluorescence is isotropic, is incoherent. Is there polarization in the first place?
In the first place, it'll depend if the molecule is asymmetric, then it will. But otherwise, you are actually using polarized light and inducing polarization.
Oh, I see.
So that's how
So
it
it's not so much the emission, it's the excitation
It's
is
the excitation
polarized
is
that gives you
polarized.
the asymmetry that you
and
detect.
then you look at the co and the cross. Yeah.
Can I ask one more quick question? Why does that correction work so well when you assume that the absorption and scattering are the same at your excitation wavelength and with a Stokes shift, I don't know, 100 nanometers, 150 nanometers, whatever, you know that the scattering is going to be whatever, 20% different, but if there are any
Why it
absorption,
works
why does it work
in the
so well?
synchronous, you mean, right?
No, well,
No,
yeah,
even-
that too, but even in that basic assumption where you get intrinsic fluorescence by assuming that everything is the same
Yeah,
at
yeah.
350 as opposed to 500 or whatever.
I think, I mean, the absorption coefficient and the scattering coefficients are not very different. If you look at the numbers, they're actually not very different as you go along the visible regime. But I think if you go to the NIR and if you're going down to UV, further UV, then maybe there'll be a problem.
But if you have an absorption peak within that Stokes band, then that will change everything, right?
If you have
an absorption peak, if you have some chromophore that has,
if you have a chromophore which has a very high absorption there, that may, yes. But then again, if it's in the visible and you have fluorescence and elastic scattering, both will show you dips at that point due to that chromophore. So as long as it's visible, so it's okay. Yeah.
You have shown the emission spectrum of the tissues, I mean, intrinsic emission spectrum of the tissues, and then you have deconvoluted the spectrum in smaller peaks. What are these peaks for? I mean, there are a number of peaks after deconvolution.
In the synchronous.
Yeah.
See, in the synchronous, what you see is you have a spectrum, and when you're actually taking the excitation and emission, we have chosen a certain offset. Okay, the offset that you choose, supposing I choose For flavin, the offset, that best offset is 70 nanometers. So I will see maybe flavin and the other one's a little less. If I choose 100, maybe I'll see NADH. Because we actually got a better diagnostics by using 55 nanometers, we chose 55 nanometers as the offset, due to which you get the signatures of all the other fluorophores also. Otherwise, you wouldn't have gotten those. And so it looks like all these fluorophores together are playing a role, okay, in the diagnostics. So,
Very nice talk. So my question is related to the lifetime. So do you use it, or you so that lifetime can be used by using tissue phantom?
No,
or
we
do you
just-
really use in real problem?
we have actually done the fluorescence lifetime imaging on this with the system, yes.
Of the system.
Yes,
So
we have
what are the molecules you are trying to separate?
targeting,
Yeah.
right? We use 375 nanometer excitation. So in this case, it was NADH, okay, coenzyme. Then depending on what wavelengths you would like to excite with, you will be probing only one of those molecules. So if I want to, I have a 440 nanometer picosecond laser also. And if I use that, most probably I will be targeting the flavin. So flavin and NADH are the ones that we would like to target, because they are the ones that play a role.
Thank you.
Thank you, ma'am, for this informative and wonderful talk. I now request Dr. Alex Witkin, Professor, Medical Biophysics and Radiation Oncology from University of Toronto, Canada, to kindly present a memento of gratitude on our behalf to Dr. Seema Pradhan. Thank you, sir. Thank you, ma'am. We now have the next oral presentation session, which will be given by Prasant Kalita from TerraBlue XT, Bangalore. I request you to kindly be on stage.
Good afternoon, everyone. Respected faculty members, dear delegates, my dear friends, and my dear students. So at the very outset, I'd like to thank Dr. Nimal Majumdar and organizing committee for inviting me for this talk. And I'm feeling very proud to present over here because of the presence of my first mentor in research, Professor Deb. So I am presenting in front of him after a long time. So before going to my presentations, I would like to mention that my presentation is basically made focusing on the students. Most of the research, deep research is not included in my talk. So if you are more interested to know about my research, you can talk me after this session. So let's begin. So here I will talk about miniaturized ultra-sensitive technologies for medical application. Here I'll discuss two technologies. Basically, first part I'll include a portion of the research that I have done during my PhD in IIT Delhi. In the second part, I'll represent my company. So due to company ethics, I'll not discuss the research behind our inventions. So that's why I'll give focus on this IIT Delhi part. Okay. So today's my outline talk will be a little bit of introduction about endotoxins, because we have developed a device which can detect endotoxins within 5 minutes. And for these innovations, actually, I have been awarded with Ghanaian Young Technological Award. So in the second phase, I'll give a brief introduction about the company, and then I'll summarize my talk with acknowledgements. So let's begin. What endotoxin is? Endotoxins is, in microbiological terminology, it's called as lipopolysaccharide, which is remain at the surface of the gram-negative bacteria. So here you can see the blue part, lipopolysaccharide. It's remain on the surface of the gram-negative bacteria. But when it is also known as pyrogen and environmental contaminant, it's remain present in all over laboratories where bacterial culture is done or where bacteria is present. So pharmacopoeia has limited the endotoxin limit up to 25 picogram in drugs, injectable drugs. So the problem when this small molecule, lipopolysaccharide molecule, invade to your blood streams, it may lead to sepsis, which is also so sepsis is one of the most lethal cause all over the world. Almost 60% of ICU patients die due to because of the sepsis, and this high mortality is because due to the lack of early detection method. So I would also like to mention that there are certain technologies available in the market to detect endotoxins. Mostly it's a LAL assay and endotoxin activity assay, which are FDA approved. But to do all these assays, you need sophisticated instrumentations and time consuming as well. So my goal is to just to develop something that can be used by the patient bedside, and in a rapid manner we can detect endotoxins. So I'll not discuss how these endotoxins lead to sepsis. Otherwise, it will consume the whole day. But for detection of sepsis, we are taking is endotoxin as a biomarker because it's inherent component of the gram-negative bacteria. So, and secondly, it's a host reflex independent. It doesn't depend upon the patient's response to the bacteria. So directly we can detect, or within a few hours of infection, you can detect. So to detect this, you should have a basic understanding of the molecular structure such that we can make a strategy to capture this molecule. So it's a trouble causing molecules. So if you go to the molecular structure, it has a lipid part, which is hydrophobic in nature. It's a core sugar part, and another O antigen part. Okay. So it has a very high thermal stability. So by boiling, also you cannot remove this molecule. So now the thing is that what to capture this molecule? You identify the molecule is a hydrophobic nature. It some negative portion is available, phosphate group, and repeating unit of sugars. So you can use several types of receptor molecules. These are the most commonly used, which are already reported in literature. But among these, I have used antibiotic drug polymyxin B because we want to make something which is commonly available, easily storable, which is cheaper, such that our diagnostic system become much cheaper. Okay, that's how we choose antibiotic drug polymyxin B. So if you go to the molecular structure of this polymyxin B, it has 5 amine groups, you can see. So and this molecule has 2 phosphate groups. So these have some interanic interactions with this molecule. Okay. So these are the advantages of doing using this molecule I have already discussed. So now you have the trouble causing molecule, you have a receptor. Now the thing is, who will report this, that the binding is occurring or not? For this purpose, we have decided to use gold nanoparticle as a reporting agent, okay, or probing agent. Okay. So what in the first phase, we synthesize gold nanoparticle, which is a common recipe available. So then after we combine this polymyxin B drug on the gold nanoparticle surface with some chemistry, and I haven't discussed. I'm not going to discuss about the chemistry. If you're more interested, you can go cite. You can cite my paper. So after conjugation, we need to confirm that conjugation is occurring. So for this purpose, we have done UV visible spectrophotometry study and DLS measurement. Apart from this, we also done zeta potential, FTR, etc. So here what happens when this DTH molecule or GLA molecule subsequently bind to the gold nanoparticle surface, there is a peak shift due to local surface plasmon resonance. Okay, LSPR effect. So there is a slight shift in peak. And after combination of the polymorphism, there is almost about 8 nanometers of peak shift. So same thing, actually, this study has been supported by the DLS measurement. In DLS measurement, the hydrodynamic radius of the molecule actually increased. So after that, we did some OP analysis of, okay. So from OP analysis, we we found a rough estimate that at least 10 polymorphin B particle is conjugating to one whole nanoparticle. Okay. Now the thing is that now every chemical components are ready. Now how it works? First, you take a membrane. It's a hydrophobic membrane. It's not very. Though it's look very simple. Actually, it's not. We have done lots of chemical engineering on this membrane, porosity, conjugations of affinity ligands, such that it can bind endotoxins. We place this membrane over some absorbent pad, which is supported by some solid substrate. Okay. So the function of this absorbent pad is when you put a serum sample which is with LPS molecule, the absorbent pad will suck immediately the liquid part of this serum, and the endotoxin molecule will get bind to the pores of this membrane. Then we use BSA as a blocking agent to restrict the non-specific binding. Then we use this gold conjugated nanoparticle over this. So here immediately you can see some red spot develop. So after doing this, we get excited to see that our strategy is working, but we get more excited. So this is the basic anatomy of my device: the adsorbent pad, some membrane. This is real test samples. Here you can see the final structure of the device. The assay can be completed within 5 minutes. And I also like to inform you that we are the first group in the world who developed for a kit for endotoxin detection within 5 minutes. So some of the optimization process that we've gone through to develop this process, I'm not going to discuss. Yeah. So we get more excited to see that the intensity of the red spot actually is a concentration dependent of the endotoxins. As we increase the concentration of the endotoxins in the serum sample, the intensity of the spot increases. I think colors are not very clear due to resolutions. Okay. So we have done several set of this experiment with the known concentrations of the endotoxins, and initially based on that, initially we develop a color chart. So that you can compare this unknown sample with this color chart, and immediately you can have a rough estimate, matlab semi estimation of the level of infections or level of concentration present on the endotoxins molecule. So later on, we develop an Android app which can calculate out the RBC values and plot in this figure and give you a digitized endotoxin values. Okay. So previous chart that you can see over here, this is not random. Actually, this chart is made on the base of this chart. Here you can see as the concentration of the LPS increases, the death risk is also increases, and it also signifies the severity of the patient, sepsis patient. Okay, so you can also back calculate how much from this. You can see that almost one bacterial cell contains this much of endotoxin. So you can also find out the level of infection in the patient. So we have already compared with the existing technique. Here you can see this flow through assay. This is the minimum time that we have developed for this, and we have got a sensitivity around 0.1 endotoxin per unit, which is just enough to give medical significance. So this is the work that I have done in IIT Delhi during my research as a little portion. Then after that, I joined to a company called TerraBlue XT. So TerraBlue XT is a short form of TerraBlue Exploration Technology Private Limited. She is the owner, Rajlakshmi Borthakur, CEO and founder. And she has a very story behind establishing or behind this startup. Actually, she is from an arts background. She's normal BA pass, and but her second child, by birth, he become an epileptic patient, and he neither can he speak, nor can he can walk properly. So she thought, and she was very depressed, and she has done lots of studies on these medical issues and thought of solving this problem scientifically. And currently, believe me, she is more expertise in this field than me. And our company, it's a biomedical industry. Basically, we are developing wearable technologies for clinical applications. Primarily, our focus is for epilepsy and neurological disorders. And we have a strong manpower in data science, electronics, software development, and clinical research. And current employee strength is 11. Apart from this, we have also outsourced many of our works. So overall, you can say that we have about 40 employees in our company. So our mission is to make life safer, uh, such that we can give an alert or predictions of the onset of uh, seizures during epileptic patients, and they can be saved. Our company has been recognized with many awards, and one of the greatest startup from India. So you can see there are 50 million people in the world having epilepsy. India has almost about 10 million. China has 19 million. European opinion has 6 millions, and USA has almost 2 millions. But the problem is that about this number of neurologists are present currently, and for diagnosis of epilepsy, we are using EEG, which is a very big bulky instruments which are actually available in hospitals. So almost 70% of the people in developing countries neither have access to this device, they live with this same. So our motive is to develop something that we can help these patients. Okay. What is epilepsy? Actually, it's a recurrence of the seizure because of the sudden surge of electrical activity in the brain. So there is some short circuit or some chemical reaction occur in the brain which gives some abnormal signals. And that abnormal signals actually affect your whole body. The signal passes through your body, the person having this disease start acting abnormally. These are the symptoms I mentioned over here. So some parental injuries. So you can see the causes over here. But I want to show a video over here. I don't know what I see. There's a girl is dancing in a class. She has no alert, and suddenly she falls. This is called epilepsy. So there is no time to react. But if she had some device that can alert that you are going to have some seizure or going to have some shock, she could have taken some medicines such that it can be restricted or prevented. Or also think that if the girl is not in a class or in some stairs or going on road, what occurrence could have maybe happen? What is our solutions? Actually, we are providing some AI, artificial intelligence, and uh, electronics to develop these hand gloves. You wear this hand gloves, it will connect to some mobile device, it will give you alert. Okay. So I'll discuss about that later. So here you can see the ECG instruments, lots of connection, 12 to 16 electrodes are on hand. Instead of that, you can use this one, initial period. Okay. So this is ECG versus TJ. We name our device as a TJ. So what are the products that we are dealing with? Initially, we have designed two products, TJ, medical grade device for prediction of epilepsy. Second was a SHANT. SHANT means CLAM. So this is a device for mental health assessment. If some person is having depression or he is going on some angriness, so that you can measure with this device, and it will give some solution that how you should react or what to do to become calm. Okay. So these are the specification that we are looking for. mentioned, the main advantage is our technology is medical grade technologies, higher accuracy, compatible, remote access information. Remote access information means you can have the information on mobile device or laptop or computer, or maybe you can put this device to your child and you can monitor, the parents can monitor their conditions from their own mobiles. Okay. So, but currently we are transforming this device to this kind of a wristwatch device, and these two are under development, smart ring. So you just put smart ring, it will give you alert before having the seizures or mental illness. How it works? So first, there are lots of sensors, actually electrodermal activity sensors, PPG sensors, temperature sensors, and this sensor actually fitted on these globes. They will record the data from your signal, from your hand, palm, okay? And these sensors are placed in different areas of the hand. And finally, we simulate all the data to data science, big data. And then uh, first, these data were actually sent to your mobile device for Bluetooth connections, and mobile through internet, it go to the cloud. From cloud, it get processed. And finally, it will give a short form of information such that the patient can understand, because okay, so he can immediately take a measure for uh, pre-precaution he can take before occurring the event like seizure. He can take medicine, he can sit somewhere in a cool place, something like that. Sorry. uh, we already have a proprietary data set of 100 subjects. We have tested, this is the ECG device, and this is our device is wearing. And we compare our device, and we are getting a very good response, almost 99% similarity. And we are collaborated with the Nimhans Hospital in uh, Bangalore, and also we have a collaboration with Australia for epilepsy trials. Uh, Till now, we are able to detect seizure events 10 minutes before. So our target is to make it to the 1 hour, because seizure doesn't come immediately. Before that, some signals comes which actually activate your brains, and then the brains react and some signals. So we are trying to identify that. Okay. So finally, these are the parameters that we are also trying to find out. So this is all about my companies and the products. So because of my innovation in IIT, I have been awarded the Gandhi and Young Technology Innovation Award, and these are the awards that I have mentioned already. Over here is some of the documentary also made on our device, which is you can see over here. So this is the group in the IIT Delhi with whom I was working. Professor Shalini Gupta was my supervisor, and Sri Thanan, he is from Global Hospital Hyderabad. He is our collaborator to develop this device for endotoxin detections. And these are the funding agencies who actually help us to develop that word. And for TerraBlue HT, I like to thank, and they are getting funding from NetFee, CIA, and BIRAC as well. And thank you so much. Any question?
So when you say 10 minutes earlier, you get some signature.
Yes, yes.
What is that signature and how is it different? Can you talk about it or?
Yeah.
Because of
Actually,
your-
see, we have some company ethics that I cannot
know,
disclose.
I know,
So,
that is why.
but if you're more interested, we personally can discuss about it. Actually, what happens in the brain signal, actually, seizure doesn't come immediately. Something need to trigger it. Some activities, maybe that activity signal goes to your brain, right? We're trying to locate that activity. What activity is trying, actually triggering that? It can be 1 hour before, it can be 10 minutes before, right?
So in terms of what? I mean, the electric signal
It's
changes.
obviously it's in terms of electric signal. Yeah.
Changes in terms of what? I mean,
Yeah, changes
changes or
in terms
you-
of conductivity in skins, conductivity from the neurons, right? So that's how actually some sensors are placed inside head. From you conductivity you can measure. So from that you can calculate out.
And they're very different, isn't it?
They're different. But it's very hard to take out that small signals.
Exactly, exactly.
So we are working on that, and we have very good data science and they actually extract out this feature. But our ultimate motive is to such that we can extract out feature before 1 hour. So that's all.
Good, nice.
Thank you so much.
Thank you so much, sir, for your presentation. Our next presenter for the day is Ankur Gogoi from Jagannath Barua College. He'll be giving a presentation on all fiber-based synchronized illumination and image acquisition for miniature endoscopes. I welcome you, sir. And I kindly request every presenter to please stick to the time. The time for the presentation is 15 minutes so that the delegates can get 2-3 extra minutes for discussion. Thank you.
No, it's all. I mean, it just maybe extended or something. Which one is the? Uh-huh. Okay. No, this one. It's okay. Becomes very slow.
Loading a bit slow.
Oh, here? Yeah. God. Sorry. Maybe you can bring yours. I can use my pen right. Oh, it's installed. I think so. Well, is the maximum size that you can have? Oh, it's okay. Yeah, sorry for that. A very good afternoon to one and all present here. First of all, I'd like to thank the organizers for giving me this opportunity to come here to this beautiful place in this part of India and then present our work on an endoscope, ultra-thin endoscope that I have done in the National Yangming University in Taipei. So the topic of today's presentation is all fiber-based synchronized illumination and image acquisition for miniature endoscopes. Myself, Ankur Gogoi, I am an assistant professor in the Department of Physics, Jagannath Bora College in Jorhat, Assam. These are the team members in the National Youngming University and also in the University Strathclyde in Glasgow. So it's a collaborative work. So the funding was done by the Veterans Hospital in Taipei Veterans Hospital, the Ministry of Science and Technology, and then Royal Society in Edinburgh. Okay, so basically the outline of this presentation will be like this. I'll be introducing the topic to the audience, and then I'll be talking about the prime objective of this work. And then we'll be describing, of course, we'll be describing the schematic diagram of the setup we have been designing, and then it's some of the salient features, and then we'll discuss that whatever some preliminary results that you have got. And this work is basically based on a paper that has been recently published in the Journal of Selected Topics in Quantum Electronics. It's a very recent paper, just published. And then, yeah, so basically endoscopy is a word derived from two Greek words, endo meaning inside and scooping means to see. So basically endoscopy is a medical procedure used by the physicians or doctors to, peer through, to see through bodies some inside passageways. So endoscopy is basically that device, which is mainly divided into two categories. Rigid endoscopes, through which we can do some minimally invasive surgeries, and other kinds is flexible endoscopy, which we can put inside some curved tracts, like gastrointestinal, for diseases to check. So irrespective of the kind of endoscope, like whether it is rigid or flexible, it basically uses a light source, and then it is guided to the region of interest, and then that illuminates that region, and then the image is collected by a optical fibers in the tube, and that is directed to the image sensor, like CCDs or CMOS cameras or videos cameras, and so on. Basically, the typical diameter of this kind of endoscopes is, nowadays it has been reduced a lot. It's around 2 to 10 millimeter approximately. So if we can, somehow further reduce the diameter of this kind of endoscopes, what will happen that it will, decrease the discomfort experienced by the patients, and also it will allow to do some, special kind of endoscopic procedures like insertion through a needle, which will reduce the risk of infection, and also, the wound will be lower, and that will reduce the time required for wound healing. So fortunately, nowadays there are many, CMOS sensors from the detection part. As I say, there is a detection part which consists of the collection fiber and then image sensor. So nowadays there are some image sensors, CMOS sensor, which is of size as small as 0.8 millimeter, having the resolution of 12,000 pixels. And then we have some image guides, the high definition image guides, where there are more than 10,000 optical fibers, bundled in a coherent way, and in a diameter of around 0.5 millimeter. So from the detection part, it is okay. We can reduce the diameter of the endoscope. Consider, if the illumination part, we can, if we can somehow downsize the, size of the illumination assembly. Now let's see what are the illumination sources we use in present day endoscopy. So the conventional endoscopic sources actually uses xenon and tungsten halide lamps, and more recently people are using light emitting diodes due to some of the inherent advantages in there, like they are low cost, and they have higher lifetime, and also they can be ease of use. But even though they have this kind of advantages, unfortunately these LEDs are incoherent. That's why we need to use you need to use a number of optical fibers for efficient collection of photons. so that the illumination is, so that we have a proper illumination. So since we need an optical fiber bundle for this kind of efficient light coupling, which increases the diameter again to few millimeters, which will overshadow the advantages that you got from the miniaturized CMOS and then HDIG guides. Other alternative is to use a ring-shaped assembly in the other end, in the distal end of the endoscope, and also use the CMOS sensor in there. But in that case, also the need of the circuitry to operate those LEDs and then CMOS sensors will again overshadow, again increase the diameter of this kind of endoscopes. So the aim of, but now, if we can use some kind of coherent sources, like spatially coherent light sources, which means the laser, we can, through some downsized light delivery system that will help us to reduce the diameter a bit. But for endoscopy, we need white light sources. For when we say about laser, we need a supercontinuum laser. So our lab previously applied this kind of lasers to reduce the diameter to around 400 micrometer. So which was what we wanted. But the problem is that this kind of supercontinuum lasers is actually, they're very big and bulky. And then the most importantly, they're very, very expensive. And okay, you need to also consider those things while designing this kind of endoscopes for practical use in everyday use. So therefore, this is not, this kind of supercontinuum lasers may not have that kind of practical applications that are what we want. So, okay. So the objective of this particular work was to use a, alternative lighting system that will allow to take us the advantage of coherent sources and also then to do some narrowband imaging applications. So we used a RGB laser source. RGB means red, green, blue laser sources of the, of wavelength 635, 530, 2445 nanometer. So so that we can take the advantage of coherence and also do some narrowband imaging. So this is basically the schematic diagram of the endoscopic system. The RGB laser is coupled to through a customized collimator by a this multimode fiber and to the endoscope tube, and then it is allowed to fall on the sample, which may be a surgical model or a color checker for the testing purpose. Then the image is collected by a high definition image guide in there, and then it is allowed to fall on a monochrome camera. So then it is connected to the laptop, and the whole RGB laser, we are using synchronized time-lapsed illumination one after the other, and those things are controlled by this UMC4 control card. So basically this is the diagram of the endoscope. Okay, so some salient features of this endoscope is that we are using all fiber-based illumination and data image acquisition. So there are 20 illumination fibers of Na 0.57, and so leading to aperture angle of 70 degree, and then an imaging fiber high definition image guide of 10,000 pixels. So it's a focal distance of 5 millimeter and having a viewing angle of 65 degree. Okay. Secondly, as I said, we are using a RGB laser for more efficient illumination. And then, but when we're using this kind of illuminations, we are facing some problems, like lasers have spatial coherence, and that's why they have small divergence angle. And this small divergence angle is a problem. I will tell you later why. Then also speckle is associated with this kind of laser sources. Okay, so as I say, the divergence angle of the laser is divergence angle of the laser is around 10 degree, and the full field of view of the image acquisition is 65 degree. That means this illumination angle is inadequate, is not sufficient to cover the full field of view of the imaging guide. Okay, so so to solve this problem, to have a efficient illumination, this illumination angle, this divergence angle should be higher than the full field of view of the image guide. So for that, we used a pair of collimators, and then we used the multimode fiber to fall on the first collimator of Na.15, and then used another collimator to increase the divergence angle to 70 degree. So this 70 degree, now we have the illumination angle, which is sufficiently larger than the full field of view of the high definition image guide. Okay, so then the next problem is the speckle. Speckle is present with this kind of light sources, coherent sources, due to interference between different kind of wavelengths in the modes. And then to remove this kind of problems, we used a acoustic frequency mechanical stress in the order of 1 to 8 kilohertz. And then you can see the change. So without vibration, we get this kind of images, and with with vibration, the speckle is reduced. These are a few other examples with speckle, without speckle, with speckle, and without speckle. Okay, the next salient features is about narrowband imaging. So narrowband imaging is a medical, practice, medical device where it is where the wavelengths of blue and green is used to enhance the contrast in different features in the mucosa, because the blood vessels generally they absorb blue and green lights. So conventional narrowband imaging technique generally use optical filters to remove all other wavelengths except blue and green. But in our case, we can, I mean, this scheme that we have presented here with narrowband light sources, RGB light sources, we can readily achieve this kind of narrowband imaging conditions. So that's one of the salient features and one of the advantages of this kind of, illumination system. Next, when you collect the image from the sample, we use a high definition image guide and then connect the image guide to a CMOS camera. And traditionally, color CMOS cameras are used, but here we're using a mono CMOS camera for higher spatial resolution. Okay, so in a color CMOS camera, actually they use a small filters, a mosaic of tiny filters in front of the pixels to collect the color information, and then they use a demosaicing algorithm to interpolate those all the pixels. So efficient, in practice, literally they do not use all the pixels to collect all the color information. So in contrast, in a monochrome CMOS camera, no filters are used. Hence, they can collect more number of photons, and then they do not, compromise with the quantum efficiency of the detectors. And then no filters is used, and more photon will be collected, and then light can be, and at lower light conditions also, this kind of monochrome cameras will be more efficient. But one of the disadvantages, again, with this kind of sensors is that monochrome cameras will give you only grayscale image, no color image. For that, we use a synchronized time-lapse illumination and detection scheme. Like we first illuminate with blue laser, and then with the green laser, and then with the red laser. When you illuminate with the blue laser, we will get a grayscale image for that blue laser, incident blue laser, and we color code that grayscale intensity to blue, and then and subsequently we also convert these grayscale images for the green laser and red laser to green and blue red respectively, and then we reconstruct the image. To describe it in more detail, like first we, for example, we illuminate with red light, and then we get the grayscale image, then you color code to red, and then we used green laser, then you color code to green, then we used blue laser, and then color code to blue. And then to reconstruct the image, we use all the color coding, then you reconstruct the image. And for narrowband imaging, if we want to do, then we just combine the blue and the green color images. Okay. So this is one of the practical examples that we have. So it's a color checker, Macbeth color checker. So these are the grayscale intensity, then a color code, and then we reconstruct the image. So one of this, points that can be noted in there, that only the portion which is synchronized illuminated is actually reconstructed as a color image. For example, here only the portion that is illuminated with that synchronized light source is converted into color image. Okay, so these are some table which says around, like, for the RGB laser, the illuminance even at 5 millimeter away from the fiber probe is very good as compared to the conventional white lights, the LEDs which are used in medical practitioners. And then again, this color reproducibility in case of the RGB laser is better than the color reproduced by a CMOS camera illuminated with a white light source. And then these are some operations, like in mice heart. So this is the color CMOS with LED illumination. This is with mono CMOS with RGB laser illumination. And this is a narrowband image that we tried to use some, indigenously develop software. So we have to develop it more so that we can get a better narrowband image. So basically, in this work, we have described about a method in which we use synchronized RGB laser illumination and detection for miniature endoscopy, and we were able to downsize the endoscope to an order of 0.49 millimeter. It's around 490 micrometer. So that's all what I have to say. Thank you for your patience. Is there any questions or comments?
Thanks. Just a quick technical question. How big are the 3 light sources that you used? How bulky are they? You've miniaturized the endoscope or the business end, the distal end, but how big is the proximal end?
Sorry?
The light sources, the 3 blue, green, and red light sources you use are quite big and bulky, or are they quite small?
No, it's quite small. It can fit in a small box.
Oh, it does, okay.
Yeah.
You never showed us a picture of the
Yeah,
device.
I should have shown. Yeah.
Okay. So they're quite small.
Yeah, they're quite small, and then they are guided through a optical fiber.
Right.
This size of that one, maybe a few centimeters. It's not too large. Yeah.
And what kind of powers are you illuminating with?
Sorry?
What kind of powers, what kind of intensities are you using on those light sources?
It's 300 milliwatt.
Oh, 300 milliwatts.
Yeah.
Thank you, sir.
Thank you. It's quite fast. I saved your time.
I thank you all for being here for the sessions. Special thanks to all the sponsors, Atos, Thor Labs, Toshman Analyticals, DSS, Laser Science, and Hallmark. We have with us Mr. K. Raj Shekhar, Senior Territory Manager from Toshman Analyticals. I thank him for all their support on behalf of Manipal OSA Student Chapter. It's my pleasure to call him on stage, and I request Dr. K.K. Mahato, HOD Biophysics and Faculty Advisor, Manipal OSA Student Chapter, to come and present a token of gratitude to Mr. Raj Shekhar on our behalf. Thank you, sir. I request you all to kindly be at the back of the building for the lunch break. We'll be gathering at the same place at sharp 2 p.m. Thank you.